in Prague, and is a professor in the first faculty of Charles University in Prague, and obviously is a member of the European Society of Cardiology and Intensive Care, and is a member of our scientific board since 2017. Thank you, and please, the stage is yours, Martin.
I hope that everyone can hear me. It's definitely an honor to speak among the group of such a brilliant, prominent figures in the area of extracorporeal circulation and ECMO management. My talk for this afternoon is something about the routine and daily ECMO management of a VA ECMO. You see, I have no conflict of interest in relation to ECMO, and I can paste to my initial slide, and that is just to summarize all possible bridges of ECMO, and I'll speak just on bridge to something, maybe recovery in cardiogenic shock and in cardiac arrest. As it was already perfectly outlined by Thomas Miller, we have little evidence that this support or bridging in cardiac failure and cardiac arrest is meaningful, but as it's well known, the absence of evidence is not the evidence of absence that doing this is meaningful, and you see that there's a trend towards positive outcome in patients in cardiogenic shock and in cardiac arrest. So it might happen to you that you get a patient with out-of-hospital cardiac arrest with a frank and overt low cardiac output, a patient after brief resource out of the hospital. And the first what you do is that you bridge him to successful coronary angio, and this is already after the procedure. Believe me or not, after 10 days, the patient may have completely normal cardiac function and may be extubated and transferred to the cardiology department. Similarly, you see patients with a global systolic dysfunction with arrhythmogenic storm. In the middle of the night, you get a low cardiac output, and this patient needs something, and something is saving life. It's the extracorporeal pump. In general, the outline of my paper will be that after you decide and you put patient on VA ECMO, you have to think about weaning right from the start. So what we tend to do is to preserve a minimum cardiac output of 1 to 1.5 liter per minute, or prefer other unloading strategy for the left ventricle and for the right, in terms of unloading the ventricle, preventing coagulation in the ventricles and in the heart, and letting the heart to rest with very low cardiac output to keep the aortic valve opening. And if not possible, then you think about unloading, and there will be another presentation on it. You have to secure in peripheral ECMO the distal leg perfusion, protect the leg. You do daily echocardiography, ideally with lung ultrasound, and you test ventricular filling, and you test the heart with manipulating with the preload and afterload. Particularly the afterload may have a deleterious effect on recovery of the LV ejection and LV systolic function. You monitor the brain because you can have hypercirculation, you can have inappropriate oxygenation. You would prefer to put your monitoring on your right hand in terms of peripheral saturation monitoring, invasive blood pressure. Because you have to protect the heart and you bridge to heart ideally to recovery, I suggest you think about decatecholaminization and you do some cardiac protection. You protect your right ventricle on intermittent positive pressure ventilation. You should avoid right ventricular strain, and particularly the acute cor pulmonale. You have to consider that these lungs are oligemic, and your X-rays and your lungs would have much less blood flow than normal. Therefore, there's an implication for imaging. And you must be ready to change for some combination of hybrid ECMOs like VAV in Harlequin syndrome and monitor the patient's circulation. The insertion is usually percutaneous, and I'll speak about that, and the extraction is surgical, and you screen for some repercussions of your extracorporeal circuit, that is thrombosis. So this is the same patient with the cardiac arrest, I would say, with the arrhythmogenic storm. And this is 3 hours on VA ECMO. And you see the spontaneous echo contrast in the left ventricle and already forming thrombus in the left ventricle. This is really what we hate to see. This is a patient who was later confirmed after the insertion of ECMO by biopsy as having myocarditis. So what you have to do, you have to unload the ventricle and keep the aortic valve open or opening with systole. So I would really prefer to start and to titrate the ECMO to maintain some minimum cardiac output by titrating the preload and afterload of the ECMO. If it's not possible to keep the aortic valve opening, you think about, for example, Impella. You think about surgical vent of LV through the left atrial auricle with the catheter, which would require a surgical procedure. Rarely we would apply the intra-aortic balloon pump or think about the atrial septostomy. So at the end, you would probably end these days with the Impella, which is an Archimedes type of pump, which you would insert through the aortic valve in the cath lab. It would provide you with some meaningful flow, unloading the ventricle. Here you see this device being applied through the aortic valve in a patient with mechanical mitral valve. And it's not suitable, of course, if there's a thrombus in left ventricle or if there is aortic valve disease. The combination of ECMO and Impella is ECMO or ECPella, how you like it. It's very hemolysis producing combination, so you must be careful when applying this because of the side effects of the free hemoglobin. Then with ECMO, you test the patient every day. So weaning of ECMO is not possible without 24 hours a day, 7 days a week, standby echocardiography and with skills of intensive care in echocardiography. So you would wean the ECMO, you reduce the blood flow gradually to trial off, which is around 1 liter per minute. Then we test to 0.5 liter per minute just shortly with a minimum FiO2, FSO2 of 0.6 on ECMO and sweep gas flow around 2 liters to avoid right to left shunt. You unload the left ventricle with diuretics. You optimize the left ventricular and diastolic pressure to avoid pulmonary edema. So from this stage, where you have a prominent mitral regurgitation, dilatation of the mitral ring, and low cardiac output, within a couple of days, you would like to see a patient who has a I would say almost normal or definitely not elevated, too much elevated filling pressures using transmitral Doppler, tissue Doppler of the mitral ring. You see a systolic wave of the tissue Doppler adequate. You see adequate cardiac output with some reasonable VTI. And in terms of stratification, it's very nice when you see that the patient has improved his ejection fraction. And of course, with manipulation of the flow, you have to pay attention to right ventricle and interatrial septum and so on. So weaning starts already from the beginning of ECMO, and it's about cardiac protection. Concerning the leg, you insert a distal leg perfusion, which we do routinely on all VA ECMOs in our center. It's done under the ultrasound, and here you can see how I'm inserting actually the guide wire into the femoral superficial artery in non-pulsatile flow. And there's a flow coming through the CuraSafe sheets, is 6 to 7 French, where you have to think that when you wean really the ECMO to the minimum flow around below 1 liter per minute, it creates really very low flow to the leg. So it's just for the short time testing, and then you would return to 1 liter to secure the leg perfusion. Another option in certain centers, I realize, is using NIRS for the leg, or cannulate the dorsalis pedis artery and measure the pressure, or measure the blood pressure and watch the pressure curve. And when you get compromise in the distal leg perfusion, then you would apply this. So the cannula is applied as closer to the artery as possible, because there's always a thrombus creation between the return arterial cannula into the distal aorta and the prograde cannula. And this thrombus is then removed by surgeons. So I would like to stress that we insert almost every peripheral type VA ECMO percutaneously in intensive care in the cath lab, but the removal we prefer to do surgically because there is a thrombus expected in between of the arterial cannulas. Another important thing is the right ventricle. So the VA ECMO may be sometimes indicated with the right ventricular failure. If you have a patient who has got, for example, ARDS plus embolization on top of it, you may see patient with the right ventricle failure in terms of cardiogenic shock with the malfunctioning right and left ventricle in series. So independent interaction between the right and left ventricle. And this is an example of bridging of right ventricular failure from VA to VV, paying attention to the right ventricular function and the setting of the mechanical ventilation, and of course the overall therapy for this type of affection. Important implication for VA ECMO is to think that as you derive the blood through drainage cannula and you return the cannula and you return the blood into the descending aorta, you have somehow oligemic lungs. And your images may look better than they really are, because to see lung infiltrate, you need also perfusion for the lung. So the pneumonic infiltrates are less dense. And when applying, for example, contrast on the CT scan, you may think about the configuration of your ECMO. So because my talk is on VA ECMO, there's an example of applying a contrast, which is sucked out by the upper drainage cannula and reversed into the axillary artery. Another example would be derivation of the contrast coming from the SVC into the drainage cannula, where you have rather poor images of the left heart. So it takes time before you get the contrast to the place where would you like to see it. And it may need a manipulation with the ECMO flow for the short time of contrast application to get proper images. VA ECMO typically applied in a patient with the pulmonary disease, like in septic shock, or, for example, in combination with distress cardiomyopathy, or in a patient who has a lung disease with the resolution of cardiac arrest, you may get to Harlequin syndrome. So in this patient with the increase of end-tidal CO2 and increase of pulmonary circulation, you see a reduction of near-infrared spectroscopy and saturation on the right hand. So the patient may become hypoxic on the right hand and in the in the region of aortic arch. So you get hypoxia into the upper part of the body, and you have to respond to it by doing something. And to give you an example of a patient who is in refractory septic shock with a biventricular failure on aggressive mode of ventilation, this patient needs definitely VA ECMO, because there's already cardiogenic shock in this patient, regardless of the poor lungs. And this patient gradually develops within 48 hours Harlequin syndrome, already with the recovery of his cardiac output. So what you have to do with this patient, you have to think about combinations and hybrid ECMO. So you would probably apply the AV ECMO. That is, you send a part of the arterial return into the venous vascular bed, and you secure the oxygenation in the upper part of the body. So that will be my approach, to be flexible with the VA ECMO during weaning and during recovery, to demonstrate the potential of ECMO in patients with sepsis. And it was already touched by Thomas Miller. With the VA ECMO, you substitute a part of the cardiac output, and you somehow balance the decrease of systemic vascular resistance to maintain the perfusion pressure. So if we have at least a small evidence, or we have some case series suggesting that the hypodynamic septic shock can be bridged with VA ECMO, we have very little indicators to say that with conversion from hypo to hyperdynamic septic shock, we can chase the low systemic vascular resistance to maintain the blood pressure. It's been tested in children, and in adults, we can be more experimental, and maybe that you can add another ECMO and run 2 VA ECMOs to secure the vital perfusion pressures. That would be a more experimental part of my talk. At the end,
Sorry, Martin, we have to conclude. Thank you.
I have my last slide. The repercussion is just the thrombi, and we tend to insert percutaneously and remove by surgically because of the thrombus between the arterial cannulas. And that's all what I wanted to say. Thank you very much.
Great, really great, and thanks for the quite experimental configuration of the last slides. So we move to Federico Pappalardo, that is a friend of mine, and he is a professor of